So as usual, I like to start out with an image, something scenery or something like that. So this is actually the lake that my aunt had a cabin on that she left to my parents. And so this is my mom's view, very pretty view. So this is a lake I grew up on, water skiing and fishing and everything like that. Okay, this is cholestasis and circulatory disease of the liver. They're the two websites for me and Dr. Hughes for our questions for the USMLE. My Twitter, plenty of stuff posted on the Montana FP Doc one, and I'll try and get back into doing that. And then, like I said, I really enjoy general and organ pathology, natural disease. I like teaching medical students. I think as a forensic pathologist, I have good exposure to natural disease, but I'm more of a superficial look at it instead of going off into the weeds kind of and stuff like that. So please pause, read the disclaimers, make sure they do not apply to you. If they do, please stop viewing the lecture. Third disclaimer, same thing, pause, read it, make sure it does not apply to you, and if it does, don't view the lecture. And then once again, if you're interested in my teaching style, it's on the introduction presentation. These are my references. At the beginning, we'll have 2 questions. So once again, pause, look at it, see if you can come up with the answer, the idea being that you haven't had this material already, and then this helps with retention. Second question. Okay, so first of all, when you're talking about jaundice, there's 2 kind of types of substances that'll create jaundice. One is unconjugated bilirubin, and the other is conjugated bilirubin. So unconjugated bilirubin is from an excess production of it, and that's commonly through a hemolytic anemia that breaks down the red blood cells, releasing the hemoglobin, which turns into bilirubin. Also, ineffective erythropoiesis, where you have basically red blood cells and white blood cells out breaking up and everything like that. You can also have reduced liver uptake of bilirubin, and if you have an inability of the liver to conjugate the bilirubin, so it has to conjugate it, and that's what makes conjugated bilirubin. Otherwise, it stays in the unconjugated form. So physiologic jaundice of newborn, where newborn ability to conjugate just isn't quite up to speed at birth, and they can have some physiologic jaundice, or if there's hepatocellular disease. If you have an increase in conjugated bilirubin, that means you're having decreased excretion, so that can be hepatobiliary disease. So hepatobiliary disease can produce unconjugated or conjugate or both, probably frequently both, because of an inability to conjugate or decreased excretion. And then impaired intrahepatic or extrahepatic bile flow obviously has to get out. So gallstones or damaged intrahepatic bile ducts can cause abnormal flow, or compression of bile ducts, for example, a pancreatic neoplasm. So a neoplasm in the head of the pancreas can push on the common bile duct and cause obstruction, leading to jaundice. So as I said, with neonatal jaundice, fairly common. Basically, it says that the system that handles bilirubin conjugation is not mature. And so in the first 2 weeks of life, you can see some degree of jaundice because of buildup of unconjugated bilirubin, because it's just not quite prepared for it. Also, it says breast milk contains enzymes that deconjugate bilirubin, which can worsen the condition. So once it's conjugated, it can unconjugate it and then lead to a physiologic jaundice of newborn. They both would be benign, and just would need to be watched, make sure they're not something else. Hyperbilirubinemia can also be hereditary. The forms are Gallbladder syndrome, Crigler-Najjar, Dubin-Johnson, and there's another one, Rotor. It wasn't in basic pathology, so I didn't look it up, but it's along the same lines of Dubin-Johnson, but I think it actually has effects. So Gallbladder's is decreased amount of glucuronosyl transferase, which is what's going to conjugate the bilirubin. So basically, if you don't have that, you have unconjugated bilirubin increased amount, and it's fairly common. It says 7% of the population. So this would be somebody who has had intermittent episodes of jaundice during their life, but no real other problems. Crigler-Najjar type 1 is same enzyme deficiency, but it's a marked deficiency. So once again, they'll produce unconjugated, and it's usually fatal in infancy. And then Dubin-Johnson is the transport protein for the bilirubin glucuronides is not working correctly, and so it can't get rid of the conjugated bilirubin once it's made it. And it says other than the liver being really darkly pigmented, they really have a normal lifespan, and it's otherwise relatively insignificant disease process. So cholestasis. So basically this is stasis, so kind of pooling of the bile. Any type of extrahepatic or intrahepatic obstruction of bile transport will cause this, or any defects in hepatocyte bile secretion. So you could see it in the hepatocytes or in the bile tracts. If the hepatocytes can't get rid of it, it's probably going to be in the hepatocytes. If the bile ducts are obstructed, it could be within the bile, the small bile ducts, as well as potentially within the hepatocytes and everything like that. So in children, you can see biliary atresia. You can see cystic fibrosis. Remember, cystic fibrosis in the ducts basically makes a kind of a thick substance. The water doesn't get in there because the sodium doesn't get in there. Choledochal cysts and a paucity of bile ducts can do it. Alagille syndrome. In adults, usually gallstones or tumors, something blocking, so oftentimes extrahepatic obstruction, something blocking the flow of bile. And then what you see is, of course, jaundice because of the bilirubin. The bilirubin can make a person itch, so you can see pruritus, and you can also see xanthomas. So just showing extrahepatic versus intrahepatic cholestasis. This was a table, so it didn't turn out quite right, but basically on the left is extrahepatic cholestasis. These are reasons for it. Right is intrahepatic. So alcoholic hepatitis, viral hepatitis, drug-induced can cause intrahepatic cholestasis and kind of interfere with that movement of the conjugated bilirubin. And then extrahepatic choledochal lithiasis, so a gallstone in the common bile duct, biliary stricture, so something blocking flow, neoplasm, like a neoplasm in the head of the pancreas, pancreatic suocyst and everything. It's a mass lesion that could put pressure on the common bile duct and obstruct flow. So microscopically, here's what it looks like. The bilirubin, the bile is kind of yellow-green, kind of almost looks shiny, I guess, in a way, and you can see it within the hepatocytes where it can cause something called feathering degeneration, and then you can see it in the bile canaliculi and that. So I'm just showing here cholestasis. So bile duct obstruction, ascending cholangitis can lead to it. Obviously, if you obstruct the bile duct or if the ducts are inflamed, and it's going to inhibit the transfer of bile. So ascending cholangitis is usually a bacterial infection. It's an infection, so you see a fever, chills associated with it, as you'd expect with a bad infection. And obviously, since it can cause obstruction, it can lead to jaundice. Neonatal cholestasis. This is beyond the physiologic jaundice of newborn. So biliary atresia. You can have where the bile ducts just don't form. It can be extrahepatic or intrahepatic. In the fetal forms, it's oftentimes associated with congenital heart disease, sometimes polysplenia. Polysplenia is always indicative of something else, it seems like. Perinatal forms, due to injury to the biliary tree, can cause atresia of it. And then neonatal hepatitis. This is kind of an interesting condition. I've seen this at autopsy. It's not an infection, even though it says hepatitis, or not necessarily an infection. Other things can cause it. But basically the response of the infant is to produce multinucleated hepatocytes and to have some degree of cholestasis. So this was a case of extrahepatic biliary atresia. You can see it was causing basically the liver's roughly green from the cholestasis, and it's also nodular, so kind of a cirrhotic because of the damage is ongoing. And then to the right of it, you can see at the portal tract there's some degree of inflammation. Basically, you don't really see good bile ducts. This is not the absence of the bile ducts. This was basically because of the extrahepatic biliary atresia, where it didn't develop in this situation. You see, you kind of regression, I think, of it, and that you can see some multinucleated hepatocytes. And then this is neonatal hepatitis. Once again, not necessarily an infection. It can be a generalized response of the liver and neonate to a range of things where you're going to see cholestasis, and kind of characteristically, you see these multinucleated hepatocytes, which you can see at the left with the black arrows, and then at the right, you can see some other ones through low power view. This is just a random picture from the lake where my mom lives. I just thought it's really neat that it's like glass, so you can see the reflection of the trees just perfectly on the other side of it. So in comparison of these two, the primary biliary cholangitis and primary sclerosing cholangitis, primary biliary cholangitis used to be called, when I was in medical school, and for a period of time after that, primary biliary cirrhosis. So primary biliary cholangitis is mostly female, whereas primary sclerosing cholangitis is mostly male, both around similar ages, although younger in the male. With primary biliary cholangitis, you're obstructing the flow of bile, so you get steatorrhea, and you get vitamin D malabsorption. Primary sclerosing cholangitis is associated with inflammatory bowel disease, and also sometimes they can develop chronic pancreatitis as a result of the cholangitis. With primary biliary cholangitis, the classic antibody is anti-mitochondrial. You can see there 95% are anti-mitochondrial antibody positive. You can also see anti-nuclear and ANCA. With the primary sclerosing cholangitis, a fair number have ANCA, but you don't see the anti-mitochondrial. Morphologically, in primary biliary cholangitis, they have what's called a florid duct lesion, which basically marked an inflammation of the portal tract, which almost has a semi-granulomatous appearance to it. And then with primary sclerosing cholangitis, you get fibrosis of the intrahepatic ducts, and classically you see this concentric fibrosis around the ducts. So primary biliary cholangitis, autoimmune, so you can be associated with Zika syndrome, thyroiditis, rheumatoid arthritis, celiac disease. The biggest one for primary sclerosing cholangitis, I think, though, is the frequent association with inflammatory bowel disease with ulcerative colitis. So this is primary biliary cholangitis. This is the florid duct lesion. You can see basically the pronounced inflammation of the portal tracts, and then you can see slightly kind of almost semi-granulomatous, not quite, but kind of like granulomatous. This is primary sclerosing cholangitis. At the bottom right is kind of the classic appearance. So you see the bile ducts with this kind of concentric fibrosis around it. So I posted this on Twitter. One of the pathologists told me that, this might not be primary sclerosing cholangitis, and I got to consider this, that. Well, this was actually diagnosed in the hospital. It was a patient who ended up requiring autopsy. So one of the hospital pathologists made the diagnosis, not me. Okay, circulatory disorders. So circulatory disorders can basically come from impaired blood flow into the liver. So if the hepatic artery is damaged, or if you have portal vein obstruction, both of them being the source of blood to the liver. Also impaired blood flow through the liver. Sickle cell disease. Sickled cells can block the sinusoids and make blood flow very difficult. Or if it flows out, the hepatic venous outflow obstruction, like you see in Budd-Chiari syndrome. And then also if you just have basically like a low flow state, this would be impaired blood flow into the liver, but it's just because you just have a low blood pressure. There's no actually blockage of it, but you just have such low pressure that you just don't get enough. So you see centrilobular necrosis because blood comes in the portal tract and filters down to the central vein. And so those are the veins, or the hepatocytes that are most at risk. And you can see a range of stuff here. You can see necrosis. You can see if it's ongoing atrophy, you can see congestion and other things like that. So to the right of it, all the lighter yellow areas that you see, that's not fat, that's infarct. And so this was a person with liver infarct. So liver infarcts are relatively uncommon because there's two blood flow sources to it, the hepatic artery and then the portal vein. But in this one, there was infarcts. Portal vein thrombosis, so thrombosis in the portal vein. Its etiology is oftentimes due to extrahepatic obstruction, so cirrhosis, hypercoagulable states, inflammation, or intrahepatic schistosomiasis is a common one. And there's also something described in Robbins called an obliterative portal venopathy, which is just described vaguely in some minimal. So basically you can see like blockage within or once it gets out in a way. Budd-Chiari is a real classic pathologic syndrome, it seems like. So you have obstruction of two or more major hepatic veins. One isn't enough. And then it's due to basically thrombosis of those. So anything that produces a hypercoagulable state, myeloproliferative disorders can do it. Thrombophilia, antiphospholipid antibody syndrome. Hepatocellular carcinoma is really well known. Hepatocellular carcinoma is also known for causing thrombosis of the vessel that kind of goes along the vessel. Pregnancy, oral contraceptives, those are also risk factors for things like DVTs and so hypercoagulable state. So basically, since you have blockage of blood flow out, you can imagine that because of that, the liver is going to enlarge because it's going to have blood going into it, but no blood going out. So you can get hepatomegaly. Then it can probably, because of that, produce some degree of portal hypertension relatively quickly, which is going to contribute to ascites. And then obviously, if the liver is swollen and pushing against that capsule, you can see pain associated with it. And then what you would expect to see is the pathologic changes there. Thrombi in the veins, two or more, the swollen liver because of the blood buildup, and then because you have inadequate blood flow, the central lobular area is going to be at most prone for damage, for ischemic injury, and then also they would get congested because that's the last place where it flows out. So with central lobular necrosis or congestion, this is just showing a picture. So a nutmeg liver, when you hear nutmeg liver, you think about usually congestive heart failure. But the actual appearance of a nutmeg liver is something we see quite commonly at autopsy with basically acute passive congestion, acute central lobular necrosis of the liver. So it looks just like a nutmeg. You see all the little red dots evenly distributed. That's going to be the central vein regions, central lobular regions. That's where you see the congestion, and then the tan would be around the portal tract. So to the right of it, you can see the yellow arrow shows the portal tract. You can see the hepatocytes around it are nice and purple. The black arrow shows the central vein, and the hepatocytes around it are pink, so they're eosinophilic, they're necrotic, and then you see some degree of congestion as well, the sinusoids, and then there's going to be some inflammatory infiltrate there too. Okay, so pause, answer the question, and then we'll go through it. So a 24-year-old Caucasian male presents to his family physician with complaints of yellow eyes. He says that throughout his life this has occurred numerous times. One other member of his extended family has the same problem but has never experienced any negative effects and told him not to worry about it. Laboratory testing reveals a total bilirubin of 2.9 milligrams per deciliter, which is elevated. Of the following was most likely mechanism for his condition. So he has jaundice. It's genetic and really no problems associated with it. So this would be kind of a presentation for Gallbladder syndrome. So that'd be impaired conjugation of the bilirubin. And so they have too much unconjugated bilirubin because they can't conjugate. They have decreased the glucuronidyltransferase. Okay, so pause, answer it, and then we'll go through it. A pathologist is examining a section of liver from autopsy. In the central lobular region, the hepatocytes have increased eosinophilia of the cytoplasm, and there's a loss of nuclear basophilia. The periportal hepatocytes appear essentially normal histologically. Of the following, what was the most likely cause of death for the individual? So this would be an individual who has a setup for the question is describing central lobular necrosis. So that's because of usually ischemia and low perfusion. And so the central veins that get blood the last are at most risk. So A, C, D, and E would basically all cause pretty much sudden death. Whereas B, there's survival. So this would be an individual who dissected, so there's some hemorrhage, and because of that, they're probably going to be hypoperfused, low blood pressure, and that would lead to central lobular necrosis. And you'd see that because they had a half-day survival in the hospital. Okay, so once again, use reflection. Go back through, think about the lecture, and ask yourself what were 5 important points I made. And like I always say, I hope I made 5 important points. Like I said, this is in Make It Stick. Medical student they talked about went from bottom of their class, top of the class using this single technique. So I always recommend it, and it's always at the end of the thing. That's why I don't give a summary slide. I want you to summarize and help remember the information that way. So this lake is called Lily Pad Lake. So my dad said, I wonder why nobody's fished lily pad. You never see them in there. So we put down the side of this thing in our boat, which was metal heavy, put it in there, got in there, and all the lily pads made casting very difficult. I'm sure you could fly fish in there and everything like that, but for what we were doing, we caught a lot of lily pad stems, and when we were done, my dad said, okay, I see why nobody fishes Lily Pad Lake. So I hope this lecture has been useful to you and help you learn some pathology, and thank you.